Okay, good morning, everybody.
Good morning.
Hey, what a beautiful day to come in and hear about prostate cancer. Happy New Year. And happy birthday to me, you missed it. January 2nd. I'm upper middle age. 91? Upper middle age. When I say that, my wife rolls her eyes. And she says, he's 86. In 4 years, he'll be 90. Wow, that sounds old, doesn't it?
Prince Philip is old.
Gene will have some comments about the aging of our leadership here. You notice the 3 old guys trying to figure this technology out?
We did it.
I have a balance problem because of my early leader, so that's why I'm holding on here. He got me a cane, but I got vanity too. So I'm holding on here tight. Okay, let's start the show because we got a very important tandem of speakers. And we got to thank the SBP for this facility. They also have facilities down the hall. Quite a ways down there, but it's available to you all. And here's what makes this thing run. These guys are getting old. So we're looking for volunteers. And so Gene will be talking about that later on here. And newcomers, the first visitor, did you get a package of material? Okay, there's a yellow cover sheet. Please fill it out and bring it up here after the meeting. And there's an information kit in there. And Gene will give you a call and welcome you and see what we can maybe do to answer any questions you may have about this program. This is a support group. We're here to help you. Our key thing is to help you manage your own case. The doctors do not necessarily manage your case. You have to. You have to remember when you need a PSA. You have to keep a copy of all your lab reports. We suggest you put it in a 3-ring binder along with the questions that you may have and take it with you. Because if you've got some short-term memory like me, you're not going to remember much when you get home and the wife asks you, well, what did you find out? So write it down. But we're not a substitute for your doctor. Anything you hear here has not been validated by a medical professional. Even when Dr. A.J. talks, that's expressing his opinion in a generic sense. It's not specifically for you. What we hope we're doing for you is generating questions you want to ask your doctor. See? And I have found on occasion when I ask my doctor about something I've learned here, frequently I say, yeah, we could do that. See, so you need to remind them or ask questions, why aren't I doing this? Or when will this happen? And so forth. So I hope you're taking notes. By the way, you don't need to copy all the graphics and things like that, because that will be on a DVD, which you can get for $10 next month. So it's in the details. You don't have to write them down, because you'll get it when we publish it next month. Okay, what support? We have a website, and a wonderful website that has a wonderful content of information, what's new. We have a library around the corner, extensive books. Some are free over on that table, some you can rent, and some you can buy. And we got a newsletter, a wonderful newsletter. Will the editor of this newsletter please raise your hand? There he is. Then we got a summarizer, what a summarizer is of the talk. And there's the summarizer over there, Phil. So you really don't need to take too many notes because you got the summary and you got the DVD. Outreach. We're ready to give a snappy 20, 30-minute talk on prostate cancer to a group, your group, men's group, church, Rotary, or wherever, if you want to do that. But also, you are responsible for reaching out. One, guys your age should have a PSA in addition to you. Talk to them about it. We have some cards out there, brochures. Pass them around. Also, if you got sons, guess what? They're probably approaching their 50s, and because you have prostate cancer, they ought to get a PSA when they're in their 40s. So do that to your son. Nay. Monthly meeting. There's the next meeting. We got a panel of experts. Experts as patients who know about side effects. They know when the doctor says it may hurt a little, it hurts a lot, and so forth. So this is going to be a wonderful thing for you next month. They're going to tell you about their experience and the various treatments they've had, and then we're going to break up into sections of different types of treatments so you can network with that group. That's next month. Okay, let's do our traditional survey. Please, how many are here for the first time? Okay, welcome. You know, it's up to you to kind of network and talk to other people. Next month will be an opportunity for you to really network. How many have been recently diagnosed in the last 6 months? Well, you're going to find out a lot here. And be sure to ask questions. How many have had prostate cancer for up to 1 year? Okay. You got a lot of years. Up to 4 years, raise your hand, please. All right. 4 to 10 years. Let those hands go up. Now we're going. Okay. 11 to 15. Okay. Higher than 15. That's me too. Okay. Is Jack here? There he is. How many years now?
28.
28 years, and he's still smiling. Look at that. Bob, how many years?
26.
26. And what's your PSA?
Right now, 2.6.
2.6. And are you on holiday or?
I'm on holiday.
He's on holiday. See? Look at that smile. Okay. So, you know, there's wonderful advances. We're going to hear some in a moment here about prostate cancer. So, you newcomers, boy, you've got quite an opportunity to come. I think how many years you're going to be coming to this meeting. And you're going to be donating, right? Okay. For us to be able to support you, we need your support. We're a tax-exempt organization. Now this April, you're going to say, oh gosh, I wish I gave more to the prostate cancer group. See? So don't make that mistake again. Let's stay cheap. For us to avoid going into a reserve, we need to average $10. And we like bills with zero. And treatment selection is dependent upon your solution, and that's an important part. We're going to hear about the treatments and the advantages. Okay, here's today's agenda, and we're going to have my buddy Gene take over. And
As soon as he gets done funneling the money.
Okay, am I up? Yeah.
I'll use this. Should have about the month in that.
Going. Now, you can hear me okay, I hope?
Hello, 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 hello. Okay. Now, I won't go to it. Just a couple of items that I want to talk about before we get into the introductions is last week, last month, November, somebody's copious notes were left behind. And I couldn't interpret any of them. Okay, there you go. And I want to make mention of this book, which is a follow-on to Dr. Lamb's presentation in November. The book that was authored by Dr. Mark Schultz, one of the doctors at the Prostate Oncology Specialist, called The Key to Prostate Cancer. We have these out in the library for purchase. And where's Mike Corliss? Stand up if you would and just tell us. He says he'd been through the book and he really thought it was worthwhile.
Oh, geez. My name's Mike Corliss. I was diagnosed 12 years ago. I'm doing active surveillance. I've read about maybe 10 books on prostate cancer, and some of them I found really valuable. And this particular book, it's new, and I read it cover to cover, and no matter what stage you're at with prostate cancer, this book, it just has so much great information, and I love it. And I have it on my desk. I have highlighted lots of sections of it. I have little sticky notes all over it, and it's a very good book, and I highly recommend it. It's probably one of the best prostate cancer books that I've read that describes the different stages and not the remedies, but the treatments available to you.
Okay,
I highly recommend it.
thank you for that. Yes, I had read it myself, and it is very, very good information from beginning to end, from the first diagnosis to the worst type of cases. Next thing I want to mention is you're going to be hearing this every month till we start filling this, and we know it's hard to do. But we're trying to seek replacements for some of us that have been doing this for quite some time. Lyle LaRoche, our president, he's just a year younger than me, and I will soon be 80, and George has already mentioned he's 102. So we need some people to come in and help with these, and we're trying to define the activities that these people do. The vice president typically just does a lot of support. Lyle, as president, was primarily involved in community functions and helping support our group within the community. George does some meeting facilitator. He also is deeply involved in acquiring speakers to speak to us. Then the treasurer secretary, I've been handling that for some time, to do banking, counting, government reporting, and so forth. And all of these things can be split up for people if they decide it's too much. And the hotline, I've been doing that for a lot of years, and it fits very well with me because I've been through almost all the treatments there are except chemo. And so it helps me speak with people and try to get them thinking towards something that might help them. So please contact any of us. We got our phone numbers there, if you can. I remember 8 years ago that I went to my first meeting. It was then held in a church close to Kaiser and a Lutheran church. And typically we got about 20 to 30 guys. And I saw what was going on. I had just retired as a CFO. And second meeting I went in and I talked to Lyle and I says, I need to be part of this because I need something that I need to give back that I never had done before. And boy, I got hooked, I got to tell you. So got involved in helping organize and so forth. And so
You'll never find anything as rewarding, I think, if you can get involved in something like this. So enough of that. So let me try to get back to the other slide.
Double click on it? Yeah, there we go.
Yeah, but I got to get it down here. I'm having a hard time seeing that. Yay, I think we got it. So now, to get started, I want to make a little introduction to Dr. Mundt standing next to me here. He's internationally recognized as an academic radiation oncologist and educator whose career has focused on the development and implementation of novel radiation technologies and a wide number of malignancies. He's a board-certified radiation oncologist whose expertise is in gynecologic and prostate cancers using a variety of novel treatment modalities. He's co-authored more than 180 peer-reviewed journal articles and book chapters on advanced radiation oncology techniques. Do you do Windows?
I do one.
Yeah, okay. He's a very strong supporter of our group, as we are of him. We had our first meeting in this auditorium in January 2010. He and Dr. Murphy were our first speakers, and he's been our first speaker in January of every year, ever since. So welcome, Dr. Murphy, and he'll introduce Dr. Seibert.
Great.
Okay, away we go. You go there, I'll go this way.
Okay. Well, it's always a pleasure to kick off the year, and I've been friends with many people in the room. I know a lot of people in the room, and so I like it to keep it informal. So we're going to do questions and topics, and I'll stay after, and Tyler and I will both stay afterwards to, there'll be other things. So I guess who's going to be the tough guy? The tough one. So I won't point when you raise your hand. He'll be the one selecting. So, but afterwards I'll be around if anyone wants to talk about anything else. So first of all, I'd like to give some updates and perspectives about radiation and prostate cancer. There's a long history about its use. And mainly it comes down to two big areas. Definitive treatment is when we treat without surgery. We give radiation to an intact prostate, with or without hormones, with or without other drugs and things, but that's definitive treatment. We're going for a cure, but we're not having surgery. We also commonly treat adjuvantly, and that's a fancy word for just saying afterwards. So after surgery, sometimes if the PSA is rising or if there's a positive margin or something like that, we give radiation afterwards. Those are some of the big traditional areas. So let's do some terminology. There are two main types of radiation delivery. External beam, which is basically a machine. You lay on a table, the machine goes around you, and we give radiation. There are two main ways to do this method. Photons, which is in medicine, we love to have lots of words for the same thing. And a photon is an X-ray. It's an energy wave that goes through the air, and we can aim it at anywhere in the body and treat a cancer anywhere in the body. Or protons, which are particles. So they're different. One's a wave of energy, and one's a particle that goes in. And they're different, but they deliver the same thing. They deliver radiation. It's how they deliver it is a little differently. And full disclosure, Scripps used to be affiliated with the Proton Center. Now they became an independent Proton Center. We're becoming very closely allied with them in UCSD, and several of our physicians, including myself, go to the Proton Center now and work with Carl Rossi. So it's becoming, I think, what it should have been originally, just a community independent thing that lots of different doctors can work at. And I think it's becoming what I think an exciting place to be and work. So I think it's a great resource for San Diego and having Carl Rossi here. He actually, a lot of doctors make claims of fame. They've done more surgeries or this or that than anyone else. He actually can make the claim, and it's true. He probably has treated more prostate cancer patients with protons than anyone else in the world. He started in 1990 was his first patient. So he definitely now is it's getting close to 30 years of him being involved with protons. That's a long history. Radiation is typically, when it's given with external beam, over several weeks. It used to be 7 to 8 weeks. It's now getting shorter to the 4 to 5 weeks. People are still looking at trying to give it in less than a week or even less, but I think the standard practice now is still a daily treatment. The national organizations are looking at saying 4 to 5 weeks instead of 7 and 8. So if you're being treated at 7 or 8 weeks, a good question to your physician is, would I qualify for the shorter 4 to 5 weeks? And realize it's not just we're not just cutting the treatment shorter, you're giving more per day. So it's more dose. It's like if you're taking the same pill for 14 days, you're taking a bigger pill and taking it for less time. You're giving more over a shorter period of time. Proton therapy is kind of interesting because if you look at backwards. When you look at traditional X-ray treatment, that's the entire machine. That's the whole thing. It's in a room with you, and you turn it on or off, and it's a big thing. It's a huge piece of equipment that rotates around you. But look at what the machine looks like with protons. Here's a guy standing here. This is what the couch looks like. And if you strip the wall away, it's a little bit bigger than this, and it has a lot more electronic equipment. So it's kind of interesting. When you just look at it, it looks the same, but strip the wall away, you see a lot bigger things behind the wall. There's also something called brachytherapy or brachytherapy. There's, it's like Caribbean, you can say either way. What it means is internal radiation, implanting radioactive elements into the prostate. But there's two ways of doing that. Just like we had photons and protons for external beam, we have low dose rate seed pellets or high dose rate where we put needles into the body and temporarily put radioactive sources and then remove them after a few minutes and do that multiple times. So there's two ways to give external radiation, two ways to do the brachytherapy. So then, once you start adding all these different things, the first question becomes, when do you do one? What do you do? Why that one, this one, all that stuff. So I think when you're trying to decide on what type of treatment, a good question is to ask which group are you in, and these risk groups. Let's talk about risk groups. There are basically 3. There's a little bit more nuance to it, but think 3 different groups, and then you can sort of put yourself into which group that is. Something called low risk. These are men that have low aggressive factors, low PSA, low Gleason scores, that type of thing. High risk is if you have more aggressive disease and you have a high PSA, things like a high Gleason score, and I'll show you what the different groups are. And then always the middle thing, which is always hard, the middle child is always the most complicated, intermediate. So let's walk through the 3 things. But basically you need to know your PSA, you need to know your Gleason score, and you need to know your T stage, or what the doctor feels when he does a digital rectal exam. And let's walk through each one. PSA is pretty simple. It's a blood test. It's an enzyme in the blood. You get a blood test, you get a number that comes out of this, and basically you can fall into 3 different groups. Low numbers, less than 10. If you have a 4.5 or a 5.5 to a patient, that may seem like a really high number, but it's really in the lower group. It's not a super high number. I've known people in the 800s, 1,000, way super high numbers. But I've had a patient who had a 0.07 and they thought it was really high. And I go, that's a really low number. That's not a high number. Medium is in the 10 to 20 and really high is in the greater than 20. Gleason score is what the tumor looks like under the microscope. So you get a biopsy, they stick lots of needles in and get these what they call cores. They put them under the microscope and we get a report. The pathologist looks at them under the microscope and says, that looks like cancer, and then makes a judgment on how the grade of a tumor. We call a low-grade tumor not very aggressive, a high-grade tumor more aggressive. So the pathologist comes up with the grade of the tumor. I don't come up with that. The pathologist comes up with that when they look at it. So there's this other group of doctors that you don't meet that make these judgments under a microscope. It's hard just to give one number, because if you look at under a microscope, there could be high-grade areas, there could be low-grade areas, it's a complicated thing under a microscope. And a pathologist a number of years ago, Dr. Gleason, came up with a scoring system where he said, well, we can't just tell you the worst, let's say you had this whole area, but only one thing was really high grade, bad. Then the doctor used to tell us, you have a high-grade tumor. That's really different than someone who has a lot of high-grade tumor and has a different proportion of it. So Dr. Gleason came up with this, may seem weird, but you get two numbers. You score on a scale of 1 to 5, 5 being the highest and most aggressive, 1 being the least. And most people come out to be 3 plus 3. So that basically says under the microscope, you kind of have a middle aggressive tumor, kind of middle range, and there's really nothing else. There's mostly that, mostly that. So they call it a 3 plus 3. But if you're someone like a 4 plus 5, you mostly have 4 out of 5, but you have a little area of 5 out of 5. So that's where the 4 plus 5 gets into this. And it gets confusing because most people just like to add the two numbers together and say I have a Gleason 7 or a Gleason 8 or 9. In general, that works. The one place it doesn't work is Gleason 7. Because if you're a 3 plus 4, you're very different than a 4 plus 3. It may seem crazy, but those two situations. But if you think about it, if you're a 3 plus 4, most of the tumor is a 3, and there's a little bit of 4. That's versus 4 plus 3, where most of it is a 4, and there's a little bit of 3. So you can see a 4 plus 3 is a more aggressive tumor than a 3 plus 4, even though they both add up to 7. I mean, it's a little confusing. So then the last thing is what the doctor feels under exam, under a digital finger is a digit, so digital rectal exam is where the word comes from. If you can't feel anything, it just feels like a flat back of the prostate, nothing abnormal, that's a T1. And then as it gets bigger and bigger and it spreads, involves the seminal vesicles, or it gets really big, it goes all the way up to a 4. Most people are a T1 or a T2A, meaning you get a little bump. If you have a little bump on one side of your prostate, that's not a very aggressive thing. That's a T2A. But if the doctor says the whole prostate feels abnormal and they think it spread to the seminal vesicles, which are right next to on the upper part of the prostate, that's a more aggressive situation, and that becomes a T3. So let's put them all together. Someone who has a PSA below 10, whose Gleason is 6 or lower, or only has a bump or no bump on his prostate, that's a low risk situation. You have a low PSA, a low grade, and you don't really have anything that the doctor feels. That is a lot of men. That's the situation. These guys used to all be treated with surgery or radiation or other things. Today, this is active surveillance. This is why active surveillance, because this is a very not aggressive situation in general. You can't say for everyone, but in general, this is not, we have to treat you on, schedule the surgery or radiation for next week. That's not the situation. If you're a high-grade tumor, your PSA is above 20, you have a Gleason 4+4 or 4+5 or a 5+5 situation, or if your tumor has a lot of disease when the doctor examines your prostate, you're in this high PSA, you have a high PSA, high score, lots of disease on the exam, or also on scans. Now, if you have anything like lymph nodes or anything that shows up on a scan, you get thrown in this high-grade box as well. As always, the middle child is going to be complicated. So the middle one is now divided into what's called favorable and unfavorable. This is important because the unfavorable men tend to act more like the high-grade people, and the favorable middle group tends to act more like the low-grade people. So it's not just a division to be complicated. It actually helps us when we think about the treatment. So when we see someone who's in the middle, it's a spectrum from favorable to unfavorable, and it allows us to sort of think this way. So let's look at this. What's a favorable person in the intermediate group? It's someone who has, the doctor does multiple biopsy cores, and if less than half of them have tumor, that's good. If you only have one of 12 cores of your prostate biopsy that has tumor in it, that's a good situation. So you could have less than half, or only one of these kind of middle things. PSA between 10 and 20, Gleason 3+4, notice the 3 comes first. Or you can feel more than just a little bump on the prostate. But this is still a pretty good situation. That's different than if you have lots of cores that have tumor, or you have more than one of these factors. PSA, you could have a PSA of 15, a Gleason of 4+3, and lots of bumps on both sides of the prostate. That's more of this group. So now how do we, as a doctor, think of how to treat these? These are going to be my opinions, as Jean was saying, not consensus from all doctors. So let's look at each treatment. So if you're in this really low risk, low aggressive group, it's active surveillance. That was not true 10, 15 years ago. But if you have any of these factors and you're being told we got to rush to whatever treatment, the answer should be, why can't I be active surveillance? That's a good question. And so if you have these things, that's a good thing. You need to be monitored for it because we need to know if you stay in this group, because not everyone who starts in a group stays in the group. We all know people, they're starting to do this, but they change. So if you stay in this box forever, I think we had someone 12+ years active surveillance, I think a few minutes ago. If you stay in that box, then you don't need treatment. You could stay just getting active surveillance. The only downside is you need to get a repeat biopsy. We used to say once a year, but now it doesn't have to be that frequently. If you've had yearly biopsies that show you're still in this box, then you don't need treatment. But the question is, do you really need a biopsy every year? Maybe you can have a newer scan every year to see if you're changing, and we'll talk about that in a little bit. But you don't do treatment until it becomes necessary. It's not necessary in this group. That's a big change in our medical thinking. I've been in the field for 30 years, or plus 30 years. We treated all these men before. This was common. They had surgery, they had radiation, they had lots of things. Today, that's not the case. That's a big advancement in prostate cancer. So a good question to ask is if you're on active surveillance, do I actually need to get treatment? The answer is things don't change or only change a little bit, you don't need it. So if the cancer becomes in another one of those boxes, if it jumps into another box, you need to get, in general, you should get treated. The only exception is if your other health problems are serious, then it's kind of silly to treat the prostate cancer if you have bad heart disease, if you have terrible heart disease or multiple strokes and you're very ill. Is prostate cancer really the one we should be running after? Probably not. My father had several strokes, several heart attacks, and I could never get a straight answer from his doctors who drew the PSA test, but they got a PSA, and his PSA was 5. And he forced someone into getting a biopsy. The urologist said he was forced, but I'm sure my father's good at it. He was forcing people. So he got a biopsy, and he had a 3+3. So a 3+3 tumor and a 5. The last thing we should do is treat him with all his other health problems. But he wanted to get treated. So he would fly around the country looking for a urologist to do surgery. I said, you shouldn't do that. He said, oh, you're just a rad onc. You want to irradiate my prostate. I said, no, I don't want to. We shouldn't do anything. He's like, why not? I said, your health problems make your other health problems more important than the prostate cancer. He would never listen until he passed away. He wanted something done to his prostate. And it was just, he drove my mother nuts for years and years and years. But I think it might have made him feel better because he had all the other problems he couldn't, deal with. So it might have been a good escape, but my poor mother was driven crazy by it. The other situation that maybe we should treat is you could stay in the low-risk box, but you're on imaging, the tumor looks like it's growing in the prostate. On fancy MRI imaging, that's an example, or on other imaging, the color Doppler looks a lot worse, this type of thing. But you still stay in the low-risk box. That's someone we might want to treat. And I'll talk about why in a bit, but the spoiler alert is we want to treat you before you fall in another box that needs hormones and other more aggressive things. We want to nip it before it becomes something more serious. So hopefully we can catch it before the patients become too advanced. The worst, and I've had patients like this, they're active surveillance, they never go back to the doctor, and they come in with a bone metastasis 8 years later. That's a terrible situation. We should not have that. We should have the situation, you get followed periodically, you don't obsess with it, you just get the PSA, occasionally, and then you deal with it if it needs to be dealt with, and you don't deal with it if it doesn't need to be dealt with. Not coming in like the 1988 would be the typical story that patients would present to the emergency room with metastatic prostate cancer. We don't want that today. We want to not have that ever happen. So the good news is there's a lot of more sophisticated imaging of the prostate, much better than CAT scans and other normal, regular scans that can really tell us, hey, that prostate tumor is growing even before the PSA and other changes are happening. And if it is growing, here's an example on something that Dr. Seibert's going to talk about, a new kind of MRI and restriction spectrum imaging. Here's a prostate gland, here's the rectum, and lo and behold, I always like when imaging has colors because it makes it easier to see. There's a prostate tumor here, but even if this started growing, but you still are low risk, we should start biopsying that spot, and the MRI can help aim the needle instead of blind biopsies anywhere in the prostate. So the treatment option, let's say you get treated, radical prostatectomy, external radiation with either protons or photons, brachytherapy with the seeds or with this. There's lots of ways to do treatment. So which one is best? And the answer is no one is best. There's not one right way for everybody. One treatment may be good for one patient, bad for another. The treatment is a very personal decision. It should not be made in the doctor's office. It should be made around the kitchen table at home. When you talk about things after you've met with lots of different people, don't feel, if someone's telling you, I have an opening to schedule you for whatever, radiation or surgery next week, just say, no, let me think about things over the weekend or home or 2 weeks, or, don't think about it for the next 5 months and but think of it in the next reasonable amount of time and make a decision about what to do. Don't make snap decisions on incomplete information. That's the whole reason for the existence of this group, to learn and make reasonable, informed, be open-minded, become involved. Don't just say, whatever you want, doctor, do what you want. That doesn't help us. Because we want people to be involved in the decision. Some physicians more than others, but in general, most of us want someone who really is invested in what's going on with their own body. Because it is your body that's being treated, not my body, your body. So surgery versus radiation. This was a big deal back in the day when we treated all the low-risk men. Every patient with a low-risk disease today gets active surveillance, I think is appropriate. Back then, we talked to them about surgery versus radiation. We had long discussions about this whole, and the problem is, both do really well for curing the prostate cancer. So there isn't like one does better than the other one. I know some doctors will say one's better than the other. There's no proof that one is better than the other one. The difference is the toxicity of the one. Surgery and radiation have very different risk to your body. Fortunately, both radiation and surgery have improved a lot over my career of 30 years. There's no comparison to what it used to be like before IMRT, before the robotic surgery, before protons were more common. There wasn't a comparison to what it was like. Today, there's all these new things. Intensity modulated radiation, which is just a fancy way to say we're focusing the treatment more just on the prostate. And if you focus better, you'd give less dose to the rectum and bladder. You don't have to go to medical school to realize less dose to the rectum and bladder, good, less problems. And that's basically, but it's a sophisticated way. Image-guided radiotherapy, you'll hear from doctors talking to IGRT, and what that is, it's using imaging. The C11 scan can be put into the computer, and we can use it to target. We're using imaging to guide us to treatment. But now the machines, the photon machines and the proton machines, can take images of your prostate on the table and move the treatment to aim better while you're laying on the table. This is the only proton center that I know of in the country that can do imaging in the room and align you to, so we have a really advanced methodology here, which is exciting. Fortunately, and I really mean fortunately, toxicity has really improved. So either what you get, the risk is much lower than it used to be. That doesn't matter to you as much because it's still your body having the side effects. Fortunately, though, these treatments are better than they used to be. If you go back to my world of radiation, a common question now is photons versus protons. IMRT is a very good method. Protons is a very good method. It's the jury is still out saying which is better. I have to admit, theoretically, I think protons do get an edge because they can theoretically conform better. Has that been proven? Not yet, but I do believe there is a reason to think they could be better. Is that proof? No, it's opinion, but it's still, I think the good news is you can get very good treatment with either the photons or the protons. So again, you are part of that decision of which one. This is a little trickier. External radiation versus the internal radiation. That's really trickier because Both are very effective in treatment, but they have a lot of different time commitments. External beam, as I said, used to be 7 to 8 weeks, now it's 4 to 5 weeks, it's getting shorter. Brachytherapy could be as little as 1 day. The seeds are 1 day that we put the seeds in. So that's attractive if one needs the problem with, daily treatment, doing that. But the toxicity profile, again, is different. The radiation has less bladder toxicity or irritation to the bladder, but it can cause some rectal bleeding. Fortunately, it's down now below a 1 to 2%, but to the person, if I say, oh, the risk is 1 to 2%, to the patient, it's either 0 or 100%, right? You either have it or you don't. But to the doctor, it's an infrequent thing. Patients often think if anything can go wrong, it will go wrong for me. But that can't be, because then everyone would have everything going wrong, right? So, but that's a common belief a lot of people have. So radiation from the outside, not so bad for the bladder. There is some risk to have some bleeding in the rectum. We're not talking blood gushing out or anything, but you can see blood in the toilet water, and you might need to have some, we do a little lasers to get rid of the bleeding, like you can think of it almost like an internal hemorrhoid, even though it's not a hemorrhoid, but it's a little vessel bleeding and dripping some blood. Don't go to the emergency room if that happens. That is just an outpatient, and even a steroid enema could heal that by soothing the bleeding area, and you might not even need even a laser treatment. Brachytherapy, there are many people that think it might be better for sexual function. That's not proven, but there is a feeling by many people that maybe putting just the seeds in, you might disturb the nerves nearby less. So there's some people that believe that. I tend to think that could be true. So a man who's younger, who's very sexually potent, we bring up seeds as a possibility because that could be a way to help preserve the sexual function. When you become more in this intermediate level, we tend not to do active surveillance routinely. We tend to do something to this group of men. That doesn't mean in the coming years, active surveillance won't be used in this group, but it's not routine like it is when you have the low risk group. So if you start having some more of these other factors, active surveillance is not commonly brought up. You can bring it up, but the physician will probably say, well, if you were low risk, we could talk about that, but you have some factors that make it a little more aggressive. You're very healthy, you're 57 years old, you have many years ahead of you, probably we want to do something. The treatments then become complicated. It could be surgery, it could be external photons or protons, it could be brachytherapy. So that's like the old discussion all over again. The nice thing in this group, hormonal deprivation, ADT, androgen deprivation therapy, the Luprons and all those other ones, actually aren't commonly done in this favorable group. So there's a good reason to think favorable versus unfavorable. I am not a medical oncologist like Mark and others are, so that's my opinion where the divide for hormones and non-hormones. But you should listen to the people that give the hormones. But in many of my patients that we have this group, we just do radiation or surgery and not do hormonal therapy. But when you start getting more unfavorable factors, like more cores you have multiple PSA high and Gleason 4+3, you can see the ADT, which is code for androgen deprivation therapy. A lot of doctors, and I have to admit, I sometimes say hormone therapy. It's not hormone therapy. It's anti-hormone therapy. It's lowering your hormones. It's easy just to say hormone therapy, but it's a little kind of a misnomer. You should say 6 months of things like Lupron, Casodex, those kind of drugs, and there's a complicated how much, how long, all these things. But in general, when you're this intermediate one, you can see we tend to add it into the situation. That's why we like to, if you're active surveillance, if you jump up to intermediate, we want to catch you when you're favorable intermediate, because if you jump up all the way to unfavorable intermediate, hormones are on the table, and many people don't like the luprons and things. It's hard on you. Surgery is still a possibility. I'm not a surgeon, again, so I'm going to say, I think we're in the favorable intermediate. Surgery is a fine option. When it starts getting more of these factors, surgery becomes less desirable. The reason it's less desirable is not that you can't have surgery and get the tumor out and everything, but you often need radiation afterwards. And if you need radiation afterwards, now we're exposing you to both the side effects of surgery and the side effects of radiation. Maybe that's getting a little much, because they're very different and you get the potential risk of both. So it's still a possibility, but I think a little less desirable. But again, caveat, I'm not a surgeon. So the thing that I think is kind of interesting is whether we should do external radiation and the Lupron treatments, or we should do a shorter external, add a boost of seeds, and then also have the anti-hormone therapy. There's a lot of clinical trials. There was a big one that came out of Canada that suggested doing the seeds on top of a shorter course of external being a way to keep the PSA under control longer. And they were able, a very bright doctor in Canada, she did this trial and she showed that the longer you were able to stay off needing anti-deprivation therapy, the Luprons later, if you got the combo versus the one. That's not proof that it's better, but it's a strong suggestion. Maybe the seeds can be added and help patients. Turn the clock back 10, 15 years, seeds used to be used as the sole therapy for prostate cancer because the low-risk men could be well treated by just having the seeds. Today, we don't treat the low-risk men anymore. So when we do seeds, it's often as a boost on top of external beam. If you have really favorable intermediate risk disease, seeds alone might be a good thing. But you gotta be really a small little tumor, good urinary function. I'm not saying there isn't a role for just the seeds, but today it's usually on top of the external radiation. The good news, if brachytherapy is used as a boost, the treatment is not as long. That is a good thing. We do give less of the external radiation. And if you give less, not only is it shorter, but we don't give the more per day, there's more tolerance to the rectum and the bladder and other normal. So there's a way it could help with the toxicity risk. Now let's look finally at the high-risk people that have a PSA in the 30s, of Gleason of like 9. Those men typically get external radiation, photons or protons. We often add that boost. We like to do that. This wasn't true a few years ago, but this is becoming our recommended treatment. And then look here, the length of the Lupron gets longer because it's more aggressive. You got to be more aggressive with the anti-deprivation therapy. So it was 6 months in the other group, but it's a lot longer in this group. But if someone has poor urinary function, if they're waking up all the time at night, they've had a TURP, that Roto-Rooter procedure in the past, or disease spread outside the prostate, we tend not to do the boost with the seed. We just treat with external radiation alone and add the 18 months of this. Notice I don't have surgery here, and I don't put surgery there not because people don't get that, and there's many people that think it might be helpful. I think that there's too much chance you're going to need to come back and me have to treat you anyway, because there'll be disease left behind or the PSA starts to climb. So then, for sure, you're starting to get into toxicities of radiation and toxicities of surgery, and that's just, it's putting your body through too many things. But there are groups of people that believe you should get a prostatectomy in this group of patients. Then there's a group that we treat after surgery. We commonly treat after a prostatectomy, and we could either do it immediately, not like the same day, but soon thereafter, or delayed when the PSA starts to climb. Not everyone's PSA is going to climb. Many people are cured with surgery, but if the PSA starts going up, we often come back into the picture even though the primary treatment is surgery. This can be very disappointing for a patient because they chose the surgery to get one thing and done, and then suddenly they're back in my office talking about radiation. It's a disappointment, but many people don't need radiation after surgery. So it isn't like if everyone did, then it would be silly to do surgery. But since many men can be cured, surgery is still a treatment for prostate cancer. So immediate or you get the surgery, they get the pathology report. There are some men who should get radiation quickly, not quickly, but planned, not waiting for the PSA. And that's a group, we get men who have a positive margin. Medicine is full of bad terminology. We like to use positive sounding words for bad things. Positive margin is not a good thing. It means tumor left behind. Negative margin is a good thing, so it's bad. A positive HIV test, no one's going to say, great, that's a bad thing. You don't want HIV. So we talk in these positive and negatives, and it's flipped. So we use the word progress. Oh, your tumor progressed. That's a bad thing. A patient may hear progress and think, good, right? You hear, oh, the tumor progressed. That's a great thing. No, it's bad. The tumor's growing. But doctors, for some reason, we adopted all these flipped. The worst one is the positive negative. So positive margin, tumor left behind. Seminal vesicle invasion. The prostate makes seminal fluid, and it's stored in the seminal vesicles, which are these little storage bins right next on top of the prostate. If the tumor goes into the seminal vesicles, that means it's much more advanced than being limited to the prostate. And disease spread outside the prostate to lymph nodes or to the bladder or something. If you have any of those things, we like to recommend radiation, not to wait for the PSA to start going up. That's an uncommon thing today because we're waiting in general till your urinary function recovers from the surgery, because when you have a prostatectomy, often your urinary function really falls down and then it starts coming back up. If we jump in when your urinary function is really, not doing well, we're not going to help your healing. So we often have to wait for someone to improve before we treat. But these factors we like to treat. If someone had surgery, had some of these bad things, and the urinary function really improves and you're doing really well, a radiation doctor is going to say, I really want to do something before we know the PSA is going to start going up because there's tumor left behind. But a lot of times urologists and others wait for the PSA to come up. So it's not common today to give radiation planned after surgery. Most commonly, it's because of waiting for the healing of the urine function. More commonly, we wait to see what happens to the PSA. After surgery, the PSA should go to 0. It should be undetectable. But if it starts over the next couple years coming back, that's a sign the tumor is coming back. And so men who have these factors, the positive margin, seminal vesicle, those type of thing, and their PSA starts going up after surgery, that's a common situation for us to give radiation. But in those men, we like having imaging. We like to know that where we're going to aim is going to be where the tumor is coming from. If we're just aiming at the bed and where the prostate used to be, and there's actually a lymph node, outside of where we're aiming, and we don't aim at it, that's not going to help you. So that's why the C11s and all these Axumans and all these other fancy scans, and we're going to show you a new one, to look for these other spots. Because if your PSA is going up, it doesn't mean it's only the bed. The tricky one is, what if it's not the bed, it's only the other places? And it's, you know, I used to go by the old argument, why does the bank robber rob the bank? That's where the money is. That idea, that's the tumor bed is most likely where it is, but it's possible it's not the only spot, or it's possible it isn't where the spot is, and that's where imaging comes in. So again, we typically give external beam, protons or photons. So protons are fine even when you don't have a prostate. I've had many patients say, I don't have a prostate, that they took it out, but I need radiation. Oh, but I can have protons. They're like, no, you can have protons. So just think protons and photons are both forms of radiation. You don't do brachytherapy in general because there's nowhere to stick anything into. So that's not in there. And now something that's happening, if your PSA starts climbing above a certain level after surgery, look what's coming into the picture. Lupron's coming into the picture. So we like to try to jump in before at a lower level so we can just give radiation and not need hormones and radiation together. So your quality of life tends to be better. So I'm going to end with showing you some old and some new on the horizon with radiation. And I'm going to transition to my colleague, Tyler Seibert. He's going to talk about some of the new imaging that's just been, several were invented and now using in prostate cancer. But there's some old uses that might come up. So don't be shocked if you're on long-term hormones and someone says, oh, we should give radiation to your breasts. You're like, first of all, I have breasts. And secondly, why is the radiation being up here? And what this is, unfortunately, long-term hormone usage, anti-hormone usage, here I am saying hormone use, anti-hormone usage, sometimes can cause painful enlargement of breast tissue. We all have breast tissue. Women, of course, have a lot more breast tissue, but we all have breast tissue. So low-dose radiation sometimes is given to try to avoid that. Oh. So it's not that common. We used to do it really commonly. But the good news is it's very short treatment, has very low risk, and the problem is if one has really large breasts that are really painful, we don't reverse that. So we try to jump in before it gets to be a problem. It's not routinely done. The new indication, now we're going to transition, is something called oligometastatic disease. So metastatic disease means your disease has spread outside the prostate. You have metastasis. It's like where the word metro, when you take a metro from one part of the city to another, the tumor goes from the prostate to somewhere else. That's where the word comes from. Radiation was commonly used for 100 years now in patients that have painful metastasis. So if you have, here's a patient with a hip, and the tumor is right in the hip, and they're having pain walking, and we commonly treat that. That's an old indication, so that's not the new, but that was putting a box around here aiming at the hip bone. It helps 80% plus of the time. It's a good use. If someone's in pain and needing narcotics for pain control, we can help with that. It also helps prevent a fracture, because if this bone breaks, if your hip bone breaks, you're going to be stuck in bed. You're going to need surgery to put a pin in different things. That's bad. So sometimes if someone has pain, the bone scan shows disease there, I come back in the picture even though it's the tumor's all over the place, but radiation is used to help prevent the bone from breaking and being stuck in bed and that type of thing. Because being stuck in bed when you're older is one of the worst health problems in the world. If you take a healthy 85-year-old and put them to bed, they're going to get sick. So being in bed is bad. If you take a 55-year-old who's healthy and put them to bed, they're going to get sick too. So it's just, you get pneumonias, you get, just bad. We don't need people stuck in bed. But there's this group of people that have a limited number of metastases. Oligo is a fancy word for just being limited. So if you have 2, 3, up to 5 metastasis, you're in this kind of special group. The old days is 1 metastasis was equal to 1,000 metastasis. It was thought of as the same patient. Today, someone with a couple, and I've met talking to several people this morning, if you just have a couple, you're really a different patient than if you have 100 of them. That's just a different patient. You should be thought of differently, treated differently, everything should be different. Previously, any metastasis meant no surgery, no radiation, no trying to do anything, just get anti-hormone therapy. Okay, but he has 1 lesion. Why are we becoming so nihilistic in treating that like 100 lesions? You know, so if the person's healthy and they have 1 lesion, why aren't we being more aggressive? But that was the past. Now there's growing evidence that men with limited numbers should be treated for cure with a combination of anti-hormone therapy, maybe the fancy chemo, you know, the newer ones that several of you have had, and very focused radiation. That's new. So let's take an example. Mr. Jones, he had favorable intermediate risk prostate cancer, a PSA of 12, Gleason 3+4, and a little bump on one side of his prostate, and he had surgery. He was good for 5 years. His PSA was undetectable, everything was fine. In the intervening years, nothing, PSAs were 0. But recently his PSA started climbing, 0.05, 0.9, it starts going up and, you know, it's going up. So that means the tumor's back. But where is it back? We don't know. But now these newer scans, this is a pelvic, think this like a slice of bread through your pelvis. These are your hip bones, your tailbone, and there's a lymph node that lights up right there. And that person has a 1 spot. That's an interesting situation, right? That's very different than if his scan lit up everywhere. So radiographic workup was a C11 scan, and this demonstrated actually a pelvic lymph node, which is this thing, and 2 lesions in 2 other bones. So he has 3 spots. That's still not that many. It's an oligo metastasis situation, and he's fine. He's perfectly healthy. So 10 years ago, that would have been Lupron. Today, now we know where things are. Should we do something about those little spots or not? That's a good, really important question. In the past, hormones alone, anti-hormones alone, now maybe we should do something about the 3 spots. And so Mark Schultz and Richard Lamb and myself and a number of different people, Fabio Almeida was a big one on this because he was the one finding all these little spots, have thought, well, we should do something. We shouldn't just think of them as the same as having 2 spots shouldn't equal 100 spots. Because if I'm going to go chasing 100 spots, that's risky and not smart. But 2, not risky and maybe super smart. You know, well, let's see. So the first question is this some rare situation that it doesn't happen ever? Well, kind of in the past it was rare because we didn't have tools to find those people. We typically waited months to years. The PSAs would go up, they would get hormones sometimes, not sometimes, and then they would come in with a scan that shows 100+ lesions all over the body. So then we could say, oh, it is kind of rare. No, it's not rare if we have tools to see. Now, many of you, I can think several in the room here, are in the oligometastatic group, which is really interesting. We have a lot of tools, C11, Axiom, and lots of tools that could find it. Here's an example of someone that has a little spot right here on one of the spine bones. You can't barely see it. It's a little dot. That's not the same thing as showing bone scan disease all over the place. So that person, the only spot that's probably causing his PSA is right there. That doesn't mean it's the only spot because, you know, it has to be big enough to be seen on a scan, but that could be the primary culprit causing the PSA rise. So it's a really interesting situation. This oligometastatic situation is kind of a new frontier in medicine. So the first question is, can we safely zap these little spots? Spoiler alert, yes, we can. It's fairly easy to do. Because these new machines, here's a good example. We just have this new SBRT. So you're going to hear the word stereotactic body radiotherapy. SBRT means sophisticated equipment, focused, a couple treatments zapped to a little tiny spot, not zapping the other tissue very much at all around it. Safe, effective, quickly. So SBRT, another, doctors love letters that, you know, SBRT, IMRT, on and on. So, but this is a really good thing. This is, the CyberKnife was the first machine that ever did this. Before the CyberKnife came along, we couldn't do this. Today, everyone else has woken up, and now lots of companies make CyberKnife kind of machines. So I have doctors go, could you CyberKnife it? And I go, well, okay, the verb CyberKnife, but it's really SBRT, because there's many machines. Protons can CyberKnife something. It's a machine that has the ability to focus and zap a little spot. So the good news is 1 to 5 sessions, very effective in eliminating a spot, very low risk of hurting someone with a toxicity. So the answer is yes, it can safely be done. But the more important question, does it help? Or is it just doing something just because we can do something? That's a really important question, because just because I can see something and shoot something doesn't mean I should do it. So we need clinical trials to do this, and there's been 2 trials, in my opinion, that really demonstrate that this is helpful, and they've just both recently been published. Again, you can see we love the letters, Seibert, Comet, and Stump. But more importantly, these 2 trials just came out. One isn't even presented in a paper yet. It's just been presented at meetings. But nonetheless, they're exciting, and we're going to look at the 2 of them. Notice they're both from Europe. Yeah, you wish America was better at doing innovative things. But thank God for our friends across the waters. So the first one, 99 patients. This one is a little different than the other ones because this one included prostate cancer, but not only prostate cancer. So let's look at this one first. Breast cancer patients, lung cancer, all oligometastatic people. So they're similar because they only have a few metastases. They were randomized either to do what you normally do, meaning don't zap any little spot, or zap all the spots. So patients receiving SBRT had twice the time before their tumor started growing. Twice the months and up to several years of now not needing any therapy at all. But unfortunately, most of them, because of lung cancer and other things, they started growing again. But nonetheless, people were in remission from their cancers longer, twice as long as if we didn't. And they lived twice as long. Not only were they in remission twice as long, they were actually alive twice as long. And that's a heavy lift when we're talking things like metastatic lung cancer. That's a super aggressive cancer. And if we're making a dent, you make a little dent in lung cancer with a new drug, it becomes a $5 billion drug in the pharmaceutical industry. This kind of thing is a huge deal because this is like a new expensive drug and we can just give a couple zaps. It's amazing. There were slightly more side effects in the SBRT group, mainly things like fatigue and some mild pain. A lot of that was due because they were a lot of lung cancer patients and we were treating around the heart and the lung. We don't do that in prostate cancer. So some of that disease side effects weren't seen in the prostate cancer group, but they didn't report them out fully separately. But let's look at the one trial that was only prostate cancer. 62 prostate cancer patients. They were a little stricter. They said only up to 3. I wish they had gone up to 5, but up to 3. They randomized to standard treatment versus metastasis-directed therapy. that could be either cut out the little spot or zap the little spot. The great majority of the people got the radiation. They didn't have surgery. There was a couple that got the lymph nodes pulled out, but the treatment of the metastasis was the idea here. They compared the time until you need anti-deprivation therapy. So until the doctors instigate the need for Lupron. And what they found was treating these little spots delayed the need for anti-deprivation therapy for almost 2 years. This is unbelievable. And there was no increased toxicity with the SBRT. Someone could say, well, did they live longer? The answer, too early follow-up to see if they did. The other trial did, probably because the lung cancer was so aggressive that, you could tell a difference faster. Prostate cancer, you're going to need to follow them longer to see that. But if you can keep someone off needing new, therapies for a number of years, that's a good thing. So I think this was a real home run for this. So if you put these together, recent trials give strong support for treating little spots found on sophisticated imaging in men with prostate cancer. I do believe that. I think I've been doing this for a while, and it was Mark Schultz and others that started me on this number of years ago, and I did it because I thought it could help. I think it can help. I believe it should help. Now there's proof that it does help, and it's much more exciting. And then when we fight with insurance companies about authorization, we can submit clinical trial data to them, and then they're much nicer, or not nicer, but at least they don't fight you as much. Remember, an insurance company, it's easier to ask permission than forgiveness. Always remember that one. Don't let the doctor go ahead and treat whatever and say, we're going to go fight with the insurance company afterwards. They don't like asking forgiveness. They like getting asked up front. So this gives us a lot of ammunition up front to get you authorized so you don't see some bill land in your mailbox, right? Because that's really what happens if they deny you. You don't want that. Treatment is well tolerated, performed over a few days, and is associated with either longer time to not needing therapy or, in some diseases, living longer. That's amazing. So currently, SBRT to all known sites in the men with 5 or less lesions is my standard practice. I really believe, and that's becoming not only me, but that's becoming common around the country. So the benefit, as remember, is not the person with the 50 lesions. That's a different situation. We got to figure out how to help them too. But at least we're looking at the ones that we're finding it. But consequently, it's important that patients with suspected metastasis undergo good imaging to find them when they're in this special group of people. We need to do that. And C11 is a method, Oxymin PET is a method. All these are methods, and we have a new method that was invented right down the street. It's kind of fun to have such a biotech-heavy world. There was a new form of MRI that Tyler is going to talk about. Tyler is a new faculty member of mine at UCSD. He has to outdo me by having a PhD in addition to his MD. I scared his son at his graduation ceremony when he was trained to say, your father is in the 29th grade. Are you looking forward to go to 29 grades? And I think that definitely scared him. So he's going to talk about, we're going to end with a new way to do looking all over the body for little spots and then using that information to target them. So here's Tyler.
Excellent. Well, thank you. So, right, I agree that this is a very exciting time for prostate cancer treatment because we have something we can do for patients with metastatic disease. That's with radiation and do things that maybe can extend life instead of just try to manage as a chronic disease. It's an exciting time. But we can't do anything if we can't see it, as Dr. Mundt was alluding to. So standard imaging, and what standard imaging means is bone scan and CT scan. That's the standard. That is literally what the clinical standard is around the country and the world. It's not very good. It doesn't find very many things. It misses a lot of tumors. And not only does it miss tumors, but it also has false positives. It shows spots that are actually arthritis or there's something else, and then you have to worry about what is it, and do you end up getting a biopsy. So you find spots that aren't cancer, and you miss the spots that are cancer. So that's a problem. Newer PET CT scans are pretty exciting. We have choline, some of you have probably had that. PSMA is also very promising. However, they're not widely available. To get a choline scan, you have to go to Arizona or Minnesota. Pretty much those are the main places people go. You also usually end up paying out of pocket for that, and it's several $1,000s. So you have to fly yourself there and then pay for it as well. PSMA is promising. It's not actually approved in the United States by the FDA yet, so we're hoping that maybe that will pan out. But at present, you have to go to one of the few places that has it for research purposes and get it there. So there's still room for improvement on the imaging side. MRI might be another option. So Dr. Mundt mentioned my PhD. I actually came to UC San Diego specifically because of the strength of the bioengineering program. I don't know if you realize that this is has been one of the leaders in bioengineering since the beginning of that field. It was the #1 bioengineering program in the country, according to the National Research Council. So that's why I came and did my PhD in MRI and in bioengineering. And it's very exciting because MRI is available at every modern hospital in the United States, as opposed to something like PET CT with choline or with PSMA. MRI systems exist everywhere. So it's just a matter of making improved protocols and sequences to use on that existing hardware. So it's very good at detecting prostate cancer in the prostate. It has become the standard for looking at the prostate. We talked about now doing targeted biopsies instead of random biopsies. The way the current standard for biopsy for prostate cancer is literally like playing Battleship. And I know you guys this is an audience, if I talk to my kids, they don't even know what that is, but you played Battleship, right? I used to play in my grandparents' house, and you're guessing. You don't know, but you guess on a grid, and you're systematic about it if you're any good, and you can get somewhere. But it'd be a whole lot better if you just wait till the other person goes to the bathroom and you look at their board. Now we're getting somewhere, right? That's what the MRI does for us. It allows us to see where the shifts are and to put the needles exactly where they are. So there's no question that MRI works for detecting prostate cancer. And the best way to do it is with diffusion MRI. So diffusion MRI, which we can get into the physics of it, is interesting, but all you need to know is that the diffusion MRI is the best part of the multiparametric MRI. There's no question about that. And studies in the US and Europe have shown that this also could work outside of the prostate for detecting disease that has metastasized or spread to other parts of your body. At UC San Diego, at UCSD, we have scientists in our group. It's the Center for Multimodal Imaging and Genetics, which I'm a part of. And this sequence has been developed, invented, and improved upon all right here in town, and has been spread in multiple places since then. So we use it standardly for targeting biopsies for men with a new high PSA. If you go to a urologist in our system, you will get this MRI, and we will put the needles in the right place. Similarly, if you're on active surveillance, this is just my opinion, and would be what I will do if I am ever in the situation of having prostate cancer, and what I recommend to my own relatives when they've been diagnosed is I would want an MRI before I got the first biopsy, but there's no way I would let anybody do a second biopsy without an MRI. I want to make sure that you're getting it's not that the Battleship method is useless. It may find something that the imaging didn't see, but there's a good chance that you missed the worst part of the tumor. And that's been proven on studies where they've done the Battleship twice, and the second time they find that you're actually a 4+3 instead of a 3+4. All right, so MRI, great studies in the UK have shown that MRI is better at detecting those higher risk, higher grade tumors than the Battleship standard biopsy. So it's also the clinical standard for looking outside the prostate cancer capsule. So looking, has the prostate cancer kind of pushed outside of the wall of the prostate, which would be a reason why you would need radiation even if you've had surgery already. And the technique that we use is called restriction spectrum imaging, or RSI. So now we have an ongoing clinical trial that my group is leading here at UCSD, and it's studying whole body MRI. So we're looking at expanding this RSI technique to the entire body. It took some advances in technology to be able to do that, to make it fast enough that you could have a patient reasonably sit in there for it to image the entire body. And the trial is open to men with metastatic prostate cancer. So that includes, I see many people in the room raised your hand. If you have metastatic prostate cancer and you're going to get any kind of treatment for it, or you're already getting some kind of treatment for it, then you could be eligible for this trial, provided you're a UCSD patient, or if you come see one of us. So if you come to see me and talk about management of your disease, or you talk to one of our medical oncologists who specialize in prostate cancer, or a urologist, then we can put you on this trial. Or men who have high risk of metastases. So if you're newly diagnosed and you fit into that high risk category that Dr. Mundt was talking about, or the unfavorable intermediate risk, then you're likely to get imaging. Your doctors, whoever they are, will order a bone scan and the CT scan. If you're getting one of those other kinds of scans, you're also eligible to get our whole body MRI, which, by the way, because it's a research study, is free to the patient and to the insurance companies. We don't even have to fight with your insurance company. We pay for it out of our grant funds for research. So that means if you're newly diagnosed with high risk or very high risk, also if you're newly diagnosed and you have disease already in your lymph nodes, or if you have already had radiation or surgery and your PSA is going up, that's another time where we do imaging, and so we could do an MRI for those patients as well. You could be on this trial. And how do we do it? The whole body MRI takes about 45 minutes. You're in the tube for up to an hour. So it is an issue for people who have claustrophobia. Sometimes they can't survive, can't quite tolerate the scan. But most men are doing quite well. And that includes both a standard MRI of the whole body, so a standard MRI but expanded to the whole body, and RSI and diffusion of the whole body from head to the knee, so not quite your entire body, but we're not very worried about your feet in this disease. Comparing MRI results to the other imaging the patient gets is one of the main things we're doing, so that's why we're doing it in patients who are already getting standard imaging. We also will compare it to choline PET, we will compare it to PSMA PET, and we have a collaboration with centers that have PSMA to do that as well. And we're also looking at treatment response. So we're talking about all these new exciting ways to treat metastatic disease. We talked about earlier the raised hands, people who've had androgen deprivation therapy, but also chemotherapy, Keytruda, Xofigo, right? So you've got all these different ways to treat metastatic disease, and then SBRT. But how do you know if it works? How do we decide if it's working? You can do big clinical trials and see if, on average, the patients in the one group did better than the other group. That's how we normally decide. But we'd also like to know, is it working for you? Because it gives you side effects, and maybe we should switch you to one of these other new ones. How do you know if you're on the right one? Well, the way we do it in cancer in general is with imaging. You look at the tumor, and you see if it's shrinking. You measure it, and you see if it's shrinking, or if it's staying the same, or if it's growing. There's a secret that's not well advertised for prostate cancer patients, which is that we don't actually have a standard way to do that in clinical trials for bone metastases. So if you have prostate cancer or breast cancer, the most likely spot for your cancer to go is the bones. But we don't have a great way to measure the change. So we think that actually this diffusion MRI to the whole body will also help us to evaluate the efficacy of the other treatments that you might get, and in clinical trials to decide whether things are working well. Hopefully you already get a sense for why this matters, but whole body MRI could be a widely available tool to look at bone metastases and disease in the lymph nodes and other places. It's looking everywhere. And unlike bone scans, MRI could also be used for the precision radiation therapy that Dr. Mundt was talking about, that Seibert knife, SBRT. A bone scan cannot be used for targeting. Okay, so I'll often have patients that have had a bone scan and a CT, and the bone scan shows a spot, and it's in their rib, but it's a 2D bone scan from the front and the back, and that's it. It's hard to even tell if it's a front rib or a back rib, right? And so I'm trying to decide, it's no big deal if I'm going to treat just a big box, but if I want to do high-dose focused therapy, I need 3D images, and the MRI can do that for us. It also, I mentioned this, decide if a treatment is working or not, new clinical trials, and also some other benefits. There's no ionizing radiation with MRI, so you don't need radiation to go places that is not cancer. And the radiation that you get with a PET CT or whatever we avoid with MRI, which would be particularly nice if you're on active surveillance, you know, and you're going to be getting scans over and over again, and you don't necessarily have disease elsewhere, so you'd like to minimize your exposure. And then IV contrast is not needed as well, so that's good for people with kidney disease, plus less needles, right? Nobody's complaining when they get less needles. So here's an example of looking at treatment response in the prostate. This is before androgen deprivation therapy. This is a patient who's going to get radiation, right? So they get hormone therapy for a couple of months before we start the radiation, and look at this blazing bright tumor on the MRI. After a couple of months of hormone therapy or androgen deprivation, the tumor has already changed and looks more favorable, right? So that's promising. It tells me that maybe this can be useful for looking at treatment response. Here's an example of a patient that is on the study, the whole body MRI trial. So this patient had a bone scan. This is the standard. And there's this little spot right here. That's it. This black spot stuff here is the same on both sides. It looks normal. It's normal. That's a kidney. That's just the contrast or the dye. So just this one little spot. I don't know if you can see it on the slide. And the radiologist or nuclear medicine radiologist who read that study said, you know, probably just arthritis. All right? So we put the patient on the whole body MRI trial, and all of these white spots are tumors. Here, 1, 2, 3, all this is right along his bone, his pelvic bones. Down here, this is in the sternum, right here in the breastbone, right? Up here is the brain, that's not a tumor. But these are all tumors, all right? And if you look at it in now cross-section, remember I said 2D images like this I can't use for treatment planning. But look at these slices, that I can very easily highlight for treatment, which is exactly what we can do for patients on this trial. And we've confirmed that these are tumors with biopsy under the microscope. Here's another patient, less dramatic, but actually in terms of impact, more important for this patient. So this patient came with high-risk disease, came to me for treatment with high-risk disease, had already had the bone scan and the CT, had already talked to the urologist, and everybody had already talked to him, he was ready to go. He knew he wanted radiation, he'd come to see me. Actually, they had told him he should have surgery, so that's not true. He didn't know if he should do surgery or radiation. And I said, well, you know, you'd be a great candidate for the clinical trial because I actually think that you're at high risk of metastases. I don't like to give that news, but I think that you are at high risk of metastases, and so I'd feel more comfortable if we look everywhere before we treat. And I don't trust the bone scan enough. So bone scan showed nothing. CT scan showed nothing. Had another CT scan for an unrelated infection, showed nothing. All right? Gets a whole body MRI, and it's a little dark on here, but there's this one white spot. That's the bladder, so that's nothing to be worried about. This is normal, this is normal. That is not normal. And here it is in cross-sectional view, this white spot right here. That is right in this bone. And it didn't show up on the other scans. And so I talked to him about it, and I said, look, this is experimental imaging, but it looks very convincing to me. I think that you have a metastasis, but only one. And based on the new trials that we talked about, I think that then we could treat you, but I wouldn't want to only treat your prostate. I would want to also treat this spot. So we got a biopsy of this spot, and it is a prostate cancer. And so that's exactly what I'm doing. I'm treating both the prostate and then doing a focal treatment to that bone region. All right? Yeah, it's back on. So thank you.
That should stay up here.
Okay.
Dr. Seibert,
Yep.
on a reoccurring PSA, as PSA raises after surgery, and you recommend the full body, how high do you want the PSA before you recommend that?
That's a great question. So we don't really know the answer.
But one rule here, since they're taping and things, repeat and the rules are, it's kind of fun. You can either repeat the question, or you can repeat only the part you want to answer. Was that the?
Very good. So the question is, in a patient who's already had, for example, surgery, and now the PSA is rising, I said that you'd be eligible for the trial. How high does the PSA need to be to get on the trial? We don't have a lower limit to do the trial, because we don't know how low is too low to detect something. We know from other types of scans that if you're below 0.5 is not very useful to get a bone scan. We do it anyway because what if we find it, but we almost always see nothing. Less than 0.2, we don't expect to see anything on PSMA. With the MRI, we're not sure, but we're testing it, so we'd like to see if you're a 0.1 and it's negative, it's still good for us to know that it was right in showing no disease. So we'd put you on the trial.
Okay, over here.
Dr. Seibert, how close, I have a pacemaker defibrillator, so I can't do an MRI, obviously. Is there any research on having an MRI that's maybe open air where they could possibly do something down the road?
Yeah, so the question here is, for a patient with a pacemaker, which is problematic for MRI, is there any hope of expanding this technology to people with pacemakers? Yes, there's hope for that. It would be down the road. You know, pacemakers and MRI, it depends on the individual patient and how strong the reason for the MRI is. Some patients, if you turn their pacemaker off, will die, so they can never have an MRI. Some are being paced for, you know, kind of a slow heart, and it's not that big of a deal to turn it off. So we wouldn't do it for a research study, but if this is shown to work, then we could go that route, or we're also looking into open MRI, kind of lower magnetic field options for this technology.
Down here, yes.
Okay, I had my prostate out 18 years ago. My PSA is now resisting hormone therapy. Boy, would I like to get in that clinical trial.
Yeah, come.
But I'm at Kaiser, so what should I do?
Well, so
No, it's actually.
So I
not that
actually
bad.
have been putting Kaiser patients on this trial. Kaiser's okay with the trial because they don't have to pay for it, right? So it's okay. So the only caveat to that is if you're a Kaiser patient and you want to go on this trial, you have to have at least one appointment with a UC San Diego, urologist, radiation oncologist, medical oncologist.
The good news is, us at UCSD, radiation doctors, we have a contract and we do all the Kaiser patients.
Yeah.
So who should
So,
I call?
Either of us, we can give you a card.
Yeah.
They have to okay you to see us. They're very nice about that. But they have to, you could say there's a clinical trial that looks for these spots. It's free. Kaiser's not charged. You're not charged.
Yeah.
Which is, he should have started with that part. I'm like, but I think it's just wonderful. But they have to get permission, and they're very nice. We work with them for years, and they're very nice about permission.
Should I talk to my doctor and call you then?
Yeah, and so for Kaiser patients, probably the one way is just to ask for a referral so that you can see us for the trial. The other is if there's any question of whether you need radiation, we do the radiation for Kaiser. So if you have metastatic disease and you say, I'd like to talk to a radiation oncologist about, whether I need treatment to this spot or that spot, then they will always send you and we can talk to you and we can put you on the trial.
It just may seem strange if you say, I'd like to see one of the radiation doctors, and you say, well, there's no need right now for, why? And you just say, they have this special thing that's free, and I'd like to have access. And then we could talk to them on the phone and tell them.
Do you have a clinical trial number?
We have a clinical trial number.
For this, there is a clinical trials coordinator.
Well, it's a registered trial.
Yeah.
So it does have,
It
does have a registration number.
We can get that information.
Okay.
Yeah.
All right. Question here.
Wait, hold on. I think So
Oh,
somebody
no,
had
he
an answer
goes-
to the trial, right?
Oh, the trial.
Oh, no, separate, okay.
Three years ago, Dr. Mundt gave me SBRT for one spot. It's climbing. Are you working with Dr. Lamb?
The PSA or the spot?
The PSA.
Yeah, okay.
Are you working with Dr. Lamb
Yeah.
on this?
Oh, with him on the trial?
Right.
He knows of it, and it's just when you're in a different city, it's harder to work with, but,
Okay, no, I'm interested in the trial, and I'm talking to Dr. Lamb on Thursday next week.
yeah, and then you just say, Richard, you call me, he knows me very well, so he might not recognize his name, because he's newer, but if you just say, oh, just reach out to, he'll tell it. The key is, it is no cost to the patient. I think that's the most important thing. And you need the normal imaging sometimes, but it's not all normal, because he could have a C11 or something.
So, no, you just need some
Other
a
imaging.
CT scan, a bone scan, some other kind of imaging within 90 days.
The Axeman.
Yeah, Axeman would be
Yeah.
fine, within 90 days of the trial, so we need to have some kind of recent imaging to compare.
Since it's so new, it can't be the sole thing. It's, it's too new, there's a new kid on the block, it has to be compared against other things that have been around.
Is RSI a key phrase on identifying your trial, RSI?
Yeah, depending on who you ask, yeah.
Well, it's important because it's not a normal MRI scan. The nice thing, it's a normal MRI machine, because if this gets perfected, it's just software that can be inserted. That's the cool thing versus needing to buy a whole new fancy dancy thing.
Okay, in the last row there.
Question one, how long does the trial last?
We've got probably, that for sure, another year or two.
And second question, how does the scans or the combination?
So the question is, how does MRI compare to PSMA? That's a main question for the trial, and we don't really have an answer. I mean, we've seen where they're showing the same tumor, so they definitely, when there's a clear tumor, they both show it, but exactly when is one going to be negative and the other negative, it's not clear.
Okay, the gentleman in the row, next row down.
So, I'm interested in trial, that's a separate thing, I don't know if I'm eligible, but in general, high risk, just finished MRT, seats on AET.
Okay.
PSA is going down, how do you know whether it's the AET doing the PSA going down? I guess, I know the NADR is going to be a long process, but.
The trick is, it's the, a couple cooks in the kitchen, who's cooking. And so you don't know. But you do know from clinical trials, combining different things help. But is the 80% of the help one thing or, 50-50? We don't know. Yeah, we don't know.
In general, just wait for AET to end and then.
Yeah, and then, but remember, everyone knows once you're on the ADT and stop, there can be a bounce. Don't get scared by this elevation that can come up and down. People get very scared and they look at one, they get this bounce and they think everything's the end. And importantly, one test doesn't determine all that therapy value. It's the series, you need the graph and seeing, because it jumps up and down, as long as it doesn't do that. That's the important thing.
Okay, yes, sir.
Yes, I recently had the radical prospectus
Yes.
with Dr. Sein, Carol Salem.
Oh, Carol Salem, yes, I know her very well.
Yeah, seems like everybody.
Oh, she's a pillar in the community. Yeah.
Okay. Anyway.
She used to work with us at UCSD before she went to Scripps.
Okay. Anyway, so she did the surgery. There was a seminal vesicle invasion. Okay, and she said she removed that as part of the surgery. So my real question is, from what you said, is that considered that my cancer metastasized, or because it was just a seminal vesicle invasion, it's metastasized?
Well, there's different ways to look at it. There isn't disease left behind. So there isn't a positive margin or things, it's been removed.
Right.
But it did get outside the prostate into the seminal vesicles. Even though that was removed, it puts it more at a higher, a little more aggressive than the other one. So even though there isn't disease left behind, the disease that you started with tend to be more aggressive. So we need to keep a closer eye on your PSAs and figure out what to do.
Yeah, that's what she said.
Okay, yes.
Ah,
My dad, Coop, here, is diagnosed in September for Gleason's. He had 12 core biopsies, 10 of them were 8s and 2 9s. They put him on ADT with Lupron and bicalutamide prior to that. He has, it has metastasized in lymph node in the left groin. The other day, they were going to do an MRI, but prostate specific. Why aren't they focusing more on the lymph node? Not, would the RSI be something together and give us a better idea of what's happening?
Sure, so question,
Question.
yeah, so the question is a new diagnosis of prostate cancer, high grade, with disease in the lymph nodes, and the next MRI is supposed to look at the prostate. Why not look at the lymph nodes, and how does the clinical trial fit into that? So the an MRI of the prostate, a general standard MRI, a multiparametric MRI, which I would consider standard now, though it's not everywhere, so you should ask. But a multiparametric MRI of the prostate is code for multiparametric MRI of the pelvis. And so it will also include and look very clearly at pelvic lymph nodes. Pelvic lymph nodes.
MRIs of the pelvic region, but never this prostate specific for the other.
Yeah, so generally, and I don't know this specific one, but generally an MRI of the pelvis will look very good. It will give a good look at the lymph nodes as well. As good of a look as we have at the lymph nodes as well.
Such a clinician who focuses on metastasized lymph node cancers?
Generally, it would be the physician who's taking care of either the systemic disease or the original tumor. So we treat lymph nodes as well.
a urologist is going to be very interested in the prostate, of course, because they're asking the question, should they remove a prostate or not remove? So they're going to be particularly interested in, is it confined to the prostate or more outside the prostate? Radiation doctors, medical oncology doctors, others who are interested in treatment of outside the prostate, in addition to inside, we do care about all these other spots, but looking at lymph nodes, looking at other things are super important. And I think if he went through that imaging, then would he be eligible for the trial? He might, then you could look everywhere.
Yeah, we would do the whole body MRI as well.
Down, everything else is down,
Oh.
but it's just the bottom line is that, what about the lymph node?
Yeah, and that
Lymphedema is in combination,
Oh.
and so we want to focus on the lymphs.
and the good news is just because the lymph node's a little enlarged doesn't mean it's cancer.
They say it's metastasized.
They think, did they biopsy it or no?
No.
Okay, so then the suspicion is high to them that it's cancer. And if it's enlarging, what look, quacks like a duck, it's probably a duck, so, but it's still not proof that it is. But if it's getting bigger and it's the only one, it's acting like that's,
So if lymph nodes look abnormal in general on either CT or MRI, both are good at looking at lymph nodes. If lymph nodes in the pelvis look like cancer, it's about an 80% chance that it is cancer. So it's not 100%, but it's pretty good. The flip side is less true. So if it looks all normal, there's still a pretty high chance that something, depending on what your risk factors are, that it missed it. So the imaging is worse at detecting it, but when it does see something, it's more likely than not that it is cancer. But it's not 100%.
So since he has imaging, and if you were to make an appointment with either one of you,
Correct.
yes. Yeah, because as long as he had other imaging.
yes.
Yeah.
Yes.
I can speak for myself, by the way.
Ah, no, but as physicians, if every patient could have supportive family members, it makes our jobs so much better.
So I have a very slow recurrent prostate cancer,
Yes.
which after my prostatectomy in 2001, I had a very slow growing, about a 16 to 18 month doubling time on the PSA. No one could find it.
Yeah.
Even as recently as, I'm up to about a 3 on the PSA, and No one could see it with an MRI. I had a PSMA scan at NIH, couldn't see it. I had an Axeman scan, couldn't see it. I just came back from Mayo Clinic and did a C11 acetate scan at Mayo Clinic, and they could see it.
Oh,
Now,
okay.
so
But the PSA was rising during that time. So if you had all three at the same time, maybe more than one would see it.
well, indeed.
Right.
So I have a new MRI scan as well as the PET CT scan for the C11. Can you use a PET CT scan for targeted treatment with radiation?
We use C11, the question is, can you use a PET scan for targeting with radiation? The answer is yes, we use it all the time. Fabio Almeida has it's been a joy having him, because he circles things with arrow, he puts like 5 arrows, and it's like, okay, I can see your arrows. He's very good because he cares about, but we can then load his and other PET scans into the computer, and then the computer fuses them together and we can aim. We can't do that with a bone scan, as Tyler mentioned.
So that's like, we would love to have you on the trial because we have all that imaging to compare to. So you absolutely would be more than welcome to.
Yeah, because a lot of people don't have all that imaging.
Right.
Do you have a limit on the number of people you can take?
Yes, but we're not close yet. There's plenty of room.
Might be the day.
Yeah. Good. That's good enough. We've got the funds to pay for it, so we.
Yeah, the exciting thing is there's not that many clinical trials today that don't charge the patient.
Yeah.
There used to be more of those, but this is not that common. When I had his slides this morning, it didn't mention that, and I'm like, ooh, is there a charge or not a charge? I didn't know, and it was exciting when he said that. I'm like, oh, maybe you should have led with that.
Hey, we have a question here.
Okay, last year I had this RS MRI at UCSD. I encountered a major difficulty with your system.
Oh, tell us.
My oncologist referred me to the RSI,
Yeah.
and then because it was done in the research part of the university, not the clinical part, they could not transfer the imaging between the two at that time. Problem one. Problem two, I didn't get any kind of a radiology report until I put pressure on the doctor to press you guys to give it. And then it just came as like a memo, not an official looking report at all. And getting the DVD also required effort on my part, and putting the heat on the clinical trial coordinator.
So this was recently?
Last year.
Last year.
So you
yeah.
use the term, this is a clinical scan.
Yeah.
Now, one of those problems I think has been solved, and that the imaging now is transferred over to
Correct.
the clinical side on the computer. But still, there's not a standard radiology report.
Right.
So this makes it rather difficult.
So, yeah, sorry, so
Is there a question there?
Yes,
No,
sir.
I think that,
Well, I think we don't want to, the issue was, he had an MRI on a research MRI last year at UCSD, and it was a bother getting the information, getting things. I can't deny that universities and bureaucracies can be a bother. So the one thing I will put out here, if anyone has a problem at UCSD, even if it's not if it's outside radiation, if you're having a podiatry appointment and someone's giving you a hard time, I can help. So come through Gene, and others come through me. But that MRI being a research one, the issues were transferring data. So do we have?
So we've got, so getting the images to the clinical system so that UC San Diego physicians can look at them is solved. That's no longer an issue. But it is true that, so as a research operation, there are some issues with keeping research and clinical operations, they're running in parallel. They're not incorporated. Once you've made something standard of care, then it gets incorporated into the standard clinical system. So this does live a little bit outside. Getting a DVD, I believe, is possible. It is somewhat difficult. Part of the issue is that there's not So it's not going to be through the standard channel where you do a records request to the clinical hospital, right? It's going to be different, so it's a little bit more difficult. It's also true that the radiologist that reads it is reading it for research purposes. I will use that information on my own judgment, or Dr. Mundt will, or the other physicians will decide how to use that knowledge to manage our patients. But officially, it's a research scan, you know, which is why it's free. So there's a report, but I agree that the reports are not going to be quite as thorough as as a report that you would get for one of our clinical scans. So if you get a pelvic prostate MRI here with RSI, it will have the full radiology report. If you get a whole body, they'll tell you it just hits the highlights. Anything abnormal, including things that aren't very concerning. So then that takes some time. I call the patient, or they come to my office and we say, look, you know, they found this cyst in your liver, nothing to worry about, but I want you to know that they found it, that kind of thing. Whole body MRI, you're gonna find a lot of stuff, right? And most of it's not gonna matter. But they'll give you those highlights, but they're not going to go into as much detail as a typical radiology report, because that would take a lot of time and we'd have to pay for it. Somebody would have to pay for it, right? So we'd have to pay, and it's not necessary to answer the question of the research. So that's an important comment, an important caveat, that it's a research study. So it's not necessarily exactly like how you would get a clinical one, for better or for worse.
Okay, any questions out there? Okay, yes, sir.
5 years ago, I had cyberknife radiation. I've had 0.0 PSA since then. For Gleason and a spike to 12. I suspect there's metastasizing going on in spotter tube. Should I see a rise in PSA?
Yes, the question is, he had Cyberknife for treatment after a rising PSA. He's been doing well, but if his PSA starts climbing again, we should go searching with imaging for the source of that rise.
And if the PSA remains 0,
then you don't need anything if it's the PSA. That doesn't mean, if the PSA stays flat, doesn't mean there isn't anything, but it gives a strong support that there isn't anything. So you're doing good. If you're not rising, you don't need all these fancy-dancy imaging, hopefully never.
Okay, we got time for 2 more questions. Yes, sir.
My question is, can prostate cancer cause elevation in the CEA marker for lung cancer?
So he's asking can prostate cancer affect a marker that's traditionally done for other tumors like colon cancer or lung cancer? Yes, it could, but it would be kind of not directly. It would have to act via, I think, going to the liver, doing something. So it would be unusual that if a CEA is rising, that is from prostate. It wouldn't be on our list of, culprits. It would be the other tumors.
Especially if the PSA is not moving, then it would be even more weird, right? If the PSA is flat,
yeah,
and the CEA is going up,
then it's not prostate.
I'd be worried about get a colonoscopy. That'd be my first start.
Yeah. You just have to look for something other than prostate.
Yeah, look for a good explanation that's more normal. Yeah.
Okay, final question in the back.
Yeah, well, Kaiser makes decisions about what type of radiation, even seeds, not seeds. They have an internal group that makes that decision. So when you see one of us, we actually send our recommendation back to Kaiser, and they internally make decisions. You do have to see, we give all their recommendations, but they have a group in Los Angeles that they work with. The head person for Southern California makes decisions on the types of things that get approved. So we submit these reports to them, and they internally discuss it. There have been patients, and many, they have pediatric patients getting protons and different things, but they do make an internal decision that we can't make because we're not Kaiser doctors. Oh, it could be me, it could be any of us. The question was who to contact at UCSD. I have my contact, you can just reach out. All the Kaiser doctors know us too. We've been working with them now for like 8 or 9 years, and we're the only radiation doctors they deal with, so they know us very, you can mention my name to them, and they know me.
Okay, what a comprehensive coverage.